Rachel Hudson, Skill 19, CPR. So essentially in veterinary practice, whenever we have a patient that goes into cardiopulmonary arrest, it becomes a team effort to get that patient stable. Oftentimes, your first thing is going to be to alert the veterinarian, and everyone on the veterinary team is going to take on different roles depending on where they are at the time that the patient has issues. Generally, you're going to be under the delegation of the veterinarian. Delegation of tasks include getting your emergency cart. So our emergency cart has endotracheal tubes, red rubbers, extra stethoscopes. It's got a box that has all of our reversal medications. It also has a recover initiative guidelines, recommendations for emergency drug dosages as well. So somebody is going to be grabbing your emergency cart. Someone is going to be grabbing the EKG machine. You've got another person that's going to be getting your oxygen hooked up. And someone else is going to be working on placing an endotracheal tube, placing a catheter, and most importantly, starting chest compressions, since that is the first step in CPR. Prior to that step, obviously, we're going to recognize that our patient is in cardiopulmonary arrest. So the patient may be in lateral recumbency, the patient may have gray or stenotic membranes, our capillary refill time is going to be reduced, respiration may be absent completely or may be occurring intermittently. Obviously, our most striking sign is going to be that our patient is not breathing. So the first step in your process of CPR is you're going to listen for a heartbeat. I am using obviously a simulation PET, but we're going to first listen for our heartbeat. Auscultation is also going to be occurring. Are we actually feeling a heartbeat? The next step in the process is going to be to check for an apical or peripheral pulse. So an apical pulse in dogs is located on the inside of their rear leg. So it should be easily felt there. In feline patients, this is going to be located in the front leg behind the left shoulder. So that would be our first step. So we've done that process. We've alerted our veterinarian. We've taken note of the fact that some of our vitals are not ideal. So our next step in the process is going to be to perform chest compressions. So essentially, following the recover guidelines, there are two theories dependent on patient conformation. These two theories, the first is cardiac pump theory. So that's used in our small dogs and cats, since these chest walls are easier to compress. Blood flow is maximized by compressing the chest wall directly over the heart using one or both hands. This holds true also for our keel-chested breeds like sighthounds and barrel-chested breeds like English bulldogs. Should be noted though, in these animals, or animal types rather, especially English bulldogs, their compressions are actually going to be done directly over the sternum in dorsal recumbency, and that's just because of their conformation. So once compressions are started, we obviously want to keep our patient in lateral recumbency, feet away from us. Using the one hand technique directly over the heart is used for small dogs and cats. I have kind of a medium-sized patient, so my compressions are going to begin at a rate of 100 to 120 compressions per minute. If I'm by myself, I'm going to be doing these compressions every 30 seconds, and after that 30-second break, I'm going to be doing 2 manual ventilation breaths, which I will demonstrate in just a moment. Obviously, in a team setting, you're going to have somebody that is working to place your endotracheal tube. So you may either use ventilation from your ambu bag, using room air, with a mask, or you may be using your anesthesia machine directly to administer your breaths using a reservoir bag. It truly just depends on what's grabbed at that moment. Because of our table, we do have a kind of an emergency stool, so to speak, that does live with our emergency crash cart. So I am on that now. So I'm going to go ahead and demonstrate. I prefer to interlock my hands. Some people prefer to just leave their hands out. You're going to want to keep your elbows out, and then I'm going to go ahead and start my 30-second compressions. One thing to note is that we want to make sure when we are administering our compressions that the chest is actually allowed to recoil. So when you're using a two-handed technique, you're going to be doing this over the widest portion of the chest cavity. So the chest should be compressed 1/3 to 1/2 of its width, and the chest wall should be allowed to expand completely between compressions. So I'm going to go ahead and do a set of 30, and then I'll switch down my camera view so that you can see me using my ambu bag, and then I will repeat that process. So it should be noted that these compressions are going to be done at 2 uninterrupted 2-minute intervals. Ideally, you want to switch out people so that that compressor is not exerting themselves. So we're going to start compressions. We're going to have, like I said, we're going to have another team member who is working on getting our endotracheal tube placed, as well as possibly placing an IV catheter. We've got another team member who is working on getting our anesthesia machine prepped, getting our EKG machine together. We're running through delegation of tasks. Usually it's done by the doctor, and she's going to be letting each team member know what to do when, and we're all just going to be verbalizing. Once we've been given an order, it's always great to vocalize, okay, doctor, I'm going to continue compressions. Okay, doctor, I'm placing a 22 gauge IV catheter, left cephalic vein, just so that we're always vocalizing the process. Obviously, that process continues until our patient is stabilized, whether that be from our compressions alone, whether that be from the use of antiarrhythmics, or the process altogether. So that is the CPR procedure.